Hi, welcome back to Off the Cuff, eviCore Healthcare's podcast. I'm your host, Emily Coe. Today, we're going to talk to Dr. Nimi Tuamokumo, our Senior Medical Director of the Radiation Oncology Program. Hi, Dr. Nimi.
Hi, Emily. How are you today?
Great. How are you?
Doing really well. Thank you. Doing really well. Congratulations on another season.
Thank you. It's our season number 3. My second season of being the host, so we'll see how much longer they'll keep me. So
I bet you'll do a great job.
Thank you.
They kept you in the season 3 renewal of your contract.
Right. Yes. Where are my M&Ms? I requested M&Ms before the thing. So yeah, and you've been with the company for 3 years, and this is the 3rd season for Off the Cuff. So there's some kind of circle of life happening there. Yep. Tell us a little bit about your practice as a radiation oncologist.
Oh, absolutely. So I am a board certified radiation oncologist. And as you alluded to, I have been with eviCore for 3, actually going on 4 years now, come June 2022. But prior to this time, I was actually a practicing clinician. I saw patients Monday through Friday in the clinic, cancer patients who are seeking out radiation therapy. And I did that for 8, almost 9 years. And then, sometimes you start getting an itch and you start thinking, what else can I do with myself, or what else is out there? And, I love patient care and love clinical medicine, but I thought, I feel like I could do more. And that's when magically, just kind of as we're talking about, stars aligning, I was contacted by the recruiter from eviCore. I was hesitant, but she just kept explaining what it is, the work that we do here. And, it really resonated with me. And, practicing evidence-based medicine, which is, I think, something that radiation oncologists really, it's kind of brought it in throughout your training, evidence-based medicine. And she always talked about, evidence-based medicine, putting the patient first. And so as I went through the process, and learned more about the company, I was like, I think this is what I want my next step to be. And hence I landed at eviCore in June of 2018. So, and have been in my current role as Senior Medical Director for 3 years now.
Great. And what does the role Senior Medical Director come with it? Like, what do you get for that? More responsibilities?
Jack of all trades. Jack of all trades.
Yeah.
So really, as Senior Medical Director, I manage the clinical and operation day-to-day within the radiation oncology solution. I also work with the guidelines. I work in developing the eviCore radiation oncology guidelines. I work with our national societies, work with our health plan clients. So you kind of have your fingers in several different areas throughout the company, but it's really rewarding, really, really rewarding.
And so you have a team of docs who report up to you, and they are all board certified radiation oncologists as well, correct?
That is correct. They are all board certified radiation oncologists with at least 5, 10, 15 years of experience. And I think that's really crucial with the radiation oncology case reviews, because they are so complex, and radiation therapy, radiation oncology, it's such a niche area, And so I think, yes, everyone's a board certified radiation oncologist. And I think that really helps with when we are speaking with the providers, the radiation oncology providers in the community, because we're able to speak their language. And I think, it's one of the things that, when you do these peer-to-peer calls, one of the things that you routinely hear from the provider on the other end is, it's so nice to speak to a radiation oncologist, because we're all speaking the same language in terms of treatment planning and, techniques and things like that. So, yes, but yeah.
And speaking of a particular niche of medicine, radiation oncologists are kind of a special breed of physicians. What is it that drove you to radiation oncology? Do you have a tremendous background in physics? So, I'm just curious, what makes you want to become a radiation oncologist?
Actually, I think the physics piece of it all is the scariest part about radiation oncology, that you don't use as much of that in the day-to-day piece of it all. Actually, radiation oncology, it's just one of those fields that nobody knows about. Physicians don't really know about it. Cancer patients don't really know about it until you
Mhm.
actually have a reason to encounter radiation oncology. But I happen to attend one of the few medical schools in the country that requires you to do a thesis as part of your graduation requirements. And so, as I was seeking out, like, what do I want to, study for my thesis, I met with a radiation oncologist, and he happened to have a project that really resonated with me. And so, that was in my first year of medical school. I mean, I looked at everyone. I think I spoke with a neurologist, OB-GYN, the broad spectrum. It wasn't like, oh, I want to find a radiation oncologist. I, I'd
He was
never heard of
probably
it, to be
begging
honest.
people to come talk to him about radiation oncology.
I mean, I don't even, yeah, I'd never heard of radiation therapy or radiation oncology before that time. And so I guess, again, it's one of those things, you meet the right person and how they can help, drive your path in life. And
Yes.
so my mentor for my thesis was a radiation oncologist. And that's how I got interested in the field, because I also had to go in and, yeah, and you don't get to do as much of that as a first year medical student. You don't get as much of the direct patient care because that's just not part of the day.
Yeah.
But I got to do that, and it's one of those rare fields in medicine where you get the luxury of spending enormous amounts of time with patients. Like, that's what you go into medicine for, is that patient care, the patient connection. And you get at least an hour with each patient. You could delve into, like, their background, their family history, who's their support system. I mean, you speak as you kind of get them comfortable with you, you learn more about them, and then you can kind of ease them into talking about radiation therapy and their cancer journey. And so it was just, every other field in like emergency medicine, surgery, they're all so fast paced, but
Mm.
this one just, it worked for me. I love the patient care aspect, the physics part of it all. Yeah, that
Right.
was peripheral.
Right. And there's probably a lot of fear for patients and their families when they come in. So you're having to manage their fears and their expectations for treatment.
Yeah, no, you're so right, Emily. I mean, there's the fear of the cancer diagnosis itself, and then there's the fear of the unknown of radiation therapy. And in terms of, what is it? How's this going to impact me? I mean, and, the questions that they have, I think part of that initial meeting and that time that you get to spend with them is helping to kind of put some of those, like, fears and concerns aside, which is like a really nice luxury. I mean, like I said, most people don't know what radiation therapy is. And so, and I think historically there's been some, sadder connotations associated with radiation. So you're able to kind of help ease them into the process and kind of help them know step by step what to expect. And you can do it in a very, like, leisurely fashion to really make sure that the patient is, as comfortable as possible
Mhm.
going in. I mean, of course, it's the unknown, but yeah.
So eviCore, we have the radiation oncology program, and we also have the medical oncology program. Would you mind explaining the difference between those two for our listeners?
So, yeah, within the medical oncology program, I believe them to be the experts, but they manage systemic therapy and all of the systemic therapy being like chemotherapy, immunotherapy, and any of the drugs that are associated with a cancer patient. But within the radiation oncology solution, we manage radiation therapy and all of the associated requests that come with a provider who needs to give radiation therapy to a patient. So radiation therapy is the use of X-rays high energy x-rays in the treatment of cancer. Now, we also have some conditions that aren't cancerous that are used for radiation therapy, but the majority of indications for radiation therapy are for cancer diagnoses. And so within the radiation oncology solution itself, we manage all of the techniques and treatment requests associated with a provider who's seeking radiation therapy for their patient.
So when when a physician submits a request, are they requesting a certain dose of radiation, a certain type of radiation? What do those requests look like?
So the request that the provider is submitting is basically the treatment plan that they have designed for their patient. So they are submitting usually 3 things to the radiation oncology solution that we use to make a determination or make a decision on the treatment. So they're usually submitting the radiation technique. So those techniques include 3D conformal radiation therapy, IMRT, you might see stereotactic body radiation therapy, proton beam. So the technique is one piece of it. They're also submitting the fractions. So that's the number of treatment visits, the treatment sessions. They'll tell us that, and then they'll tell us if they want to use a type of additional radiation modality called image guidance radiation therapy, or IGRT. And so those 3 pieces of information are what we need to be able to make a determination. Of course, we also need the clinical history, right? I mean, we need to know what type of cancer it is and the stage and whatnot. So we'll take all of that information in addition to the requested treatment technique, fractions, and use that in making a clinical determination about the request.
And so you're using the eviCore clinical guidelines to review cases, which you help create and maintain and manage those guidelines. Are your primary sources for those guidelines, are those NCCN and ASTRO? Are the guidelines heavily influenced by those?
That you've hit it right, nail right on the head, actually, with that. So the guidelines are impacted by whatever's the latest evidence. So, and that's usually through NCCN. American Society of Radiation Oncology usually will put out guidelines, evidence-based guidelines on different disease sites. American College of Radiology, as well as American College of Radiation Oncology, and we have a medical advisory board. So taking all of those pieces together is what we use to develop the guidelines. We try and make sure that we attend our national meeting that's held annually, the Radiation Oncology National Meeting, so that we can make sure if there's any updated or late breaking interesting news that will impact clinical care or the way patients need to be managed, we make sure that we're in attendance there, so that we really do want to stay on top of where the evidence is, where the literature is, where the field is as a whole in determining the guidelines. So it's a very comprehensive, complex process.
Yeah, and I know that whenever there's late breaking evidence, we like to revise the guidelines and get those updates out to benefit the patients as soon as possible. So if, for example, NCCN has an update that's a positive change for patients, then we would like to implement that change almost immediately and get the guidelines reposted with that revision.
Yeah, that's definitely our perspective. The one that just immediately springs to mind, because it's probably been one of the biggest changes in radiation oncology, was a new technique that was developed that would improve when radiation is being delivered to the brain. There's a concern that it's going to impact memory, thought process. And so research came out that if there's this type of radiation called hippocampal avoidance radiation, you use that, it could help with preservation of memory and neurocognitive functioning. And so literally immediately that was published. We took that evidence, ran it through our medical advisory board. We looked at NCCN and made sure we had that update, made so that patients could receive the right care that they need based on the evidence. So we really do try and pay attention to where is the field, what is late breaking evidence, and especially how can it benefit the patient. So, and we want to make sure they have access to whatever it is they need through their cancer journey.
That's an incredible update, actually, because I think radiation, as you said earlier, has a negative connotation to folks. And I remember hearing folks say you could get cancer from radiation therapy, which is that true this day now, this day and age?
I think, I mean, the issue then was more of the type of radiation that was being
Hmm.
delivered, and it would scatter X-ray beams throughout the body. And then
Hmm.
there would be the concern of, maybe another cancer like 20, 30 years down the road due to the
Hmm.
radiation. But now, given the advances in radiation therapy, where it's just so much more precise, um,
Yeah.
you know, we look at CAT scans, MRIs, PET scans, all of that is used in determining the radiation field. So, I kind of think of it as like a black and white television, like
Mhm.
before people would look at images in black and white. So it'd be kind of fuzzy and grainy. We've moved to high definition television.
Yeah.
I think that's what it's called now.
Yeah.
Like really, very vivid images. So we've got, we're much more sophisticated now with the treatment delivery.
Yeah.
And I think that's really cut down on a lot of the side effects that people have been worried about and associated
Hmm.
with the radiation therapy. I mean, I would actually say most patients are actually able to work. Not all, but there's a good number who are able to
Hmm.
work during the radiation therapy. I mean, it could be a 4 to 6 week course of therapy,
Hmm.
shorter, but most patients now are able to work and live their lives during the radiation therapy.
So as far as types of radiation therapy, different treatments, I know there are different types or different approaches that you've alluded to, like proton beam therapy, stereotactic body radiation,
Mhm.
stereotactic radiosurgery, and brachytherapy. Would you mind giving a little bit of a synopsis of each of those, especially brachytherapy? Is that like an applicator that you insert into the body that delivers radiation to different parts of the body?
Well, I think you kind of captured it. So I kind of think of it as like there are two types of radiation.
Mhm.
There's external radiation. So as the name implies, it's externally delivered, all from outside, versus internal radiation. And internal radiation, you actually have to put something into the body to deliver that radiation. And so brachytherapy, as you alluded to, is internal radiation. And there are different types of brachytherapy. There's some that are what we call permanent brachytherapy. And so that's like what's used in prostate cancer, where the radiation is actually put into your body and left there.
Are those the
Um,
seeds that you
yeah,
hear
the
about?
seeds,
Okay.
the seeds, the
Okay.
seeds. Yep, yep, yep. And then there's also ones that are more temporary. So, like for instance, what's done with cervical cancer or endometrial cancer, where the patient, depending on the type, depending on the stage, the patient would come in and they would get their treatment for maybe about an hour, and then they could go home. And then the radiation is delivered at that time, and when the treatment's done, the radiation's removed, and then you just go home without any radiation left within you. So, but the radiation actually goes into the body for delivery. So that's internal radiation, and that's actually not the majority of radiation. What's used for the majority of cancer patients who are receiving radiation therapy. The majority is actually the external beam radiation therapy, and that's the majority of what it is that we manage here within eviCore.
Mhm.
And those different types are the 3D conformal radiation, the intensity modulated radiation therapy. So it's also called IMRT.
Mhm.
There's the stereotactic body radiation therapy, and then the proton beam. So the 3D conformal radiation therapy is basically taking CAT scans and using radiation beams, and you target out where your tumor is and then aim those beams at the target, the tumor volume. Okay, so that's 3D conformal. And it's kind of along a spectrum, I think, in terms of sophistication or complexity. That would be the 3D conformal. And then a little bit more sophisticated type of radiation therapy is the IMRT, or intensity modulated radiation therapy. And just that one has a different property in that it's able to give higher doses of radiation because to the tumor type, because it takes into account like all the normal tissues around it. So for instance, if you're wanting to treat, say, the lung, because an individual with lung cancer. And so you have to think about, okay, this is where the tumor is. And then here are the normal tissue or like that I want to avoid and keep away from the radiation. So for instance, in the lung, you'd be considerate of the heart, you'd be considerate of your esophagus, you'd be considerate of your spinal cord, and then the lung tissue itself. So that IMRT really tries to look at what are the normal tissues around the tumor and how can we deliver the maximum dose to that tumor while minimizing the dose to those normal structures. And it allows you to play a little bit more with, okay, well, maybe I'll give a little more radiation here and less there so I can protect this organ a little bit more.
Yeah.
And so then you also have stereotactic radiation therapy. That's a lot. That's a mouthful. Stereotactic radiation therapy or stereotactic body radiation therapy. And so that's using high energy X-rays or high dose of radiation therapy and targeting a small tumor volume. It requires a high degree of precision because you're giving so much radiation all at once, but over a very short period of time. So, for instance, traditional radiation is given over 3 to 6 weeks, whereas with stereotactic radiation therapy, because you're giving so much radiation at once, you only need like one treatment session or a maximum of 5 treatment sessions.
Is that reserved for more aggressive tumors?
It's just for tumors that I would say are more that are smaller, actually. Yeah, because you can't really give a lot of radiation to a large part of the body, But if you can have a small area and you can keep it all the other important structures are away from it. Say, for instance, in the lung, right? The lung is like, say, this big, and then you've got a small tumor that's like this little. And then you can just kind of pinpoint, you can deliver radiation to that small area and spare a lot of normal tissue. So you can really only use stereotactic radiation therapy when you're able to take advantage of that principle. Okay, I can really localize that small tumor volume and give it a high dose of radiation because one of the properties or one of the principles that's really important to radiation therapy, a radiation oncologist is, you can't, every organ can receive but so much radiation, and you have to be very mindful of that so that you can safely deliver the radiation therapy. And so if you've got an area that needs to be treated and it's far away from everything, then it's much easier to say, okay, I can give a lot of radiation there and I don't have to really be too concerned that, any other structure is going to get as much radiation. So stereotactic radiation therapy is more for if it's small area that allows you to deliver as opposed to the more because aggressive in my mind, and maybe that's not the right to me, is usually it's like more widespread of a tumor burden. And so it's much better actually if it's a smaller area for the stereotactic radiation therapy. And then we have proton beam therapy as well too. And that's another type of radiation that uses protons for delivery of radiation. And that one is not as commonly done because there have been so few proton therapy centers because proton therapy were so far as the evidence shows, has really been the most beneficial for pediatric tumors or, malignancy or cancer in kids. And I mean, thankfully, that's not a large volume of cancer patients. So, but there's been increased interest in proton therapy as a modality and within radiation therapy. So there are actually now way more centers. At one point, I would say maybe about 15, 20 years ago, there were only 4 places in the United States where you could get or receive proton therapy. Okay. Whereas now, I think there's like 30, and in the next few years, there could be anywhere up to like 50 proton centers throughout the country. So that's an area that's growing within the field.
Which adult cancers are most receptive to proton beam?
So for adults, the areas that we've seen the most benefit are these rare tumors called chordomas. That really, I think I think you could go a whole career in radiation oncology and never encounter a chordoma in your life. But so chordomas, and the location, it's what's called the base of skull. They could be anywhere, but the chordoma is in the base of skull just because Like that's like this part, like take your skull and you hit here, and then you go deep, deep, deep within. And it's kind of that area where all your nerves converge. So really important areas. So you really need a high level of precision there. So chordomas have been shown to have some benefit with proton beam. Eye tumors have seen some benefit. Again, smaller areas and more critical areas. And then there are some liver tumors as well too, where there's been benefit with proton beam therapy. So it's
Great.
not a large area. I mean, it's definitely an area of investigation, and more evidence is coming. And, we're starting to see more and more where there could be a benefit for proton beam, whereas maybe there's not as much as one that people might think about. But currently, those are the areas where we can say for certain that there is a benefit. I mean, there are also certain types of tumors in what's called the head and neck region. So literally, as the name means, head and neck, that there's proton beam might be beneficial for, but it's still a very small population or a small handful of tumors relative to, what are the most common cancers, like breast cancer, prostate cancer, lung cancer. So those are, some of the most common, skin cancer. So those are like our most common cancers, right? And that's where, you see most of radiation therapy being utilized. And we haven't seen as much in terms of that potential benefit in those tumors. But the research is being undertaken, so that could change, in the next 5 years. And we'll make sure we change with it.
Right. And so skin cancer and breast cancer, lung cancer, those more common ones, are those typically treated with external beams?
Yes, those are typically treated with external beam. Prostate cancer, you do see a little bit more of the internal radiation, the brachytherapy. That's usually where people associate the internal radiation with. But in general, I would say that most of radiation oncology is through external beam radiation therapy. Yeah.
What's on the horizon in radiation oncology research? Is there anything out there that you're really looking forward to seeing new outcome studies on? Anything that you're monitoring other than proton beam?
I think one of the areas that I think radiation oncology has really done a great job of is, in a way, really trying to look at the patient and their journey in cancer, and how can we minimize how intrusive that the care we deliver is in their daily lives, but without impacting outcome. And so one of the areas that's seen a significant growth in radiation oncology is looking at the number of treatments that are actually treatment visits that are needed to deliver the radiation. And so historically, like for instance, with prostate cancer, we thought, evidence, we always did like 9 weeks. So that's Monday through Friday for 9 weeks. So 45 days that patients have would come in daily for radiation. Now, unlike chemotherapy or medical oncology, it's not necessarily like they're there for 4 hours. Usually the treatment visit's about 15 minutes, but you got to leave your home. You've got to drive in traffic. You've got to get to the doctor's office. You've got to sit there. And so, it's not just the 15 minutes for your treatment.
And
it's
if you're
like,
in a rural area,
exactly,
and we talk about disparities,
access,
determinants of health, that's
access to
really
care.
problematic.
Yeah. So one of the things that's really emerged over, I would say, the last 10 to 20 years or so is looking at, can we do shorter treatment schedules for radiation oncology patients? So like I think I was alluding to, for within prostate cancer, it was historically 9 weeks. Now, and more studies have said, hey, we don't necessarily have to do it in 9 weeks. We're now looking at 28 days in some case, which is about 4 to 5 weeks. That's half the time. Sometimes you can now do it in 5 visits with stereotactic radiation therapy. So we've gone from 9 weeks, so 45 days, to potentially as little as 5 days. We've seen the same thing in breast cancer as well, too. Again, breast cancer was traditionally sick, and sometimes it's still necessary, the longer treatment courses. But if it's not, that's where the field is moving. And breast cancer, historically, 6 to 7 weeks is what was needed to, if you had breast cancer and you needed radiation therapy. Now we've looked at the data, or radiation oncology as a field has looked and said, hey, we can maybe do this in 21 days. We can, so about 3 weeks or so, you can do it in as little as maybe 1 week. So I think that's a really patient-centered view of how we deliver care, which I think is, it's really exciting and it's really wonderful. I think for the benefit of the patient that, because quality of life, right, as more and more
Yeah.
patients are surviving, they've got quality of life. They need to, that we have to also take into account. It's not just that it's cancer and that's it. I mean, people
Right.
have lives that need to be managed. So that's an area of evolution within radiation. Is look, I mean, we're seeing it not just, it's breast cancer, it's prostate cancer, it's rectal cancer, even in head and neck cancer. So that's one direction the field is moving.
Stereotactic radiosurgery. Is
Yeah,
that
stereotactic radiosurgery is another area in which radiation therapy, we're seeing the use of that increasing. We're seeing that there's this concept where, so, ideally, if someone's diagnosed with cancer, you want it at an early stage. It's very limited to one area. We can do like a treatment, whether that's surgery, radiation therapy, and you can kind of, you can take care of it with just those. But unfortunately, there are times when the cancer is not just limited to one area and it's spread, what we call metastatic disease. And so we're now seeing that, hey, when it's spread and it's gone to other parts of the body, sometimes, it's gone to multiple parts of the bodies, but there are times where it's just in one or two areas. And just maybe we could use radiation therapy to treat those one or two areas. And then it makes the patients not, be what's called disease free, so no longer have cancer. So stereotactic radiation therapy for patients with metastatic disease is definitely a large area of emerging data. More and more research is being done into that. There's a lot more research being done, I think, into how we deliver radiation. I think we alluded to what's called image-guided radiation therapy, which is a technique that we manage. So I think the imaging has been great for radiation oncology because it is, you get to see what you need to treat before you treat it. Magic,
Yes.
right? I mean, it's something that we take for granted now, but it wasn't a part of the treatment
Yeah.
paradigm I don't know,
Is
30,
that
40
typically
years
done
ago.
with CTs, MRIs, PETs, or does it depend on the cancer?
It depends on, actually, it depends more on well, it does depend on the cancer type sometimes, but usually it just depends on the facility. But some facilities were only doing x-rays before, but as radiation has evolved, there's using more CT scans to take a picture. They basically take a picture before the radiation is delivered to make sure that you're in the right place. I mean, that's a large part of radiation is you're targeting a tumor. So you need to make sure that your target is on point. And so, that's an area that's emerging. So before it was x-rays, similar to how radiology, I think, has emerged, x-rays. And then we've used CT scans for image guidance. And now there's a look at maybe using MRIs for image guided radiation therapy. So that's another area, I think, of evolution within the field. So there's different areas that are kind of coming on board, and of course proton beam. So those are our big areas, looking at number of treatments, visits that are necessary, proton beam, image guidance. So every day there's something new.
Great. So, Dr. Nimi, you mentioned medical advisory board. So that's an external panel of radiation oncologists, right? And they review the guidelines each year?
That is correct. We have an external panel of radiation oncologists who come from large academic centers throughout the country, and they all have various areas of expertise, and they review our guidelines every year whenever it comes out, or if it comes out twice a year, and they'll give us input as we update the guidelines. And they are just such an amazing resource given their depth and breadth of expertise and experience, and they really understand the nuances of the data. So they're a great resource for our program and our guideline development.
Yeah, I think the guidelines are incredibly solid with the medical advisory board. We have you and our 14, 15 board certified radiation oncologists helping to inform the guidelines. We're using, looking to NCCN and Astro to inform the guidelines. So I would say that we are as up to date as you can be with clinical evidence for radiation oncology.
I would agree, Emily. I mean, I think the guidelines are actually the backbone of our program. I mean, it is what we use for every single case that comes our way. So, like, it's our responsibility to make sure the guidelines are as comprehensive and evidence-based and as up to date as possible. I mean, it's our responsibility to the patients, to the health plans, and to all of those we serve.
Without the clinical guidelines, it would be a free-for-all for treating patients with radiation oncology or radiation therapy. Would that put the patients at risk?
I mean, I think anytime you're utilizing radiation therapy and for any indication, but for cancer patients, there's always a risk. I mean, we look at risk benefit with when we're delivering radiation, and so we want to make sure that if the radiation is going to be delivered, that it's backed by evidence to ensure patient safety. And so we make sure that it's high quality evidence because you can't just take it for granted that you can just deliver radiation and it's fine. It has side effects and it has toxicity. And so, I think the guidelines being backed by evidence, being backed by, being based on recommendations from American Society of Radiation Oncology or NCCN or our medical advisory board, they work to ensure patient safety.
Thank you, Dr. Nimi, for joining us. This has been an enlightening conversation about the radiation oncology program here at eviCore.
Oh, thank you, Emily, for having me. It's been a great opportunity for me to speak about our radiation oncology program and the benefits that it has within just the healthcare industry, the healthcare framework. And so it's my pleasure. So thank you for having me.
Thank you for joining us for our first episode of Off the Cuff for 2022. I'll see you next month.